Hello, my name is John Sevransky. I'm the editor-in-chief of Critical Care Medicine, and I have the tremendous pleasure of being here with Bram Rochwerg, who is an associate editor for Critical Care Medicine, and Laura Evans, who's the incoming chair of the Society of Critical Care Medicine's Discovery Research Network. And we're here for our monthly edition of the highlights for the upcoming issue of Critical Care Medicine, which will be released on the 21st of February, just prior to FCCM's Congress. In this issue, there will be two late-breaking articles that will be presented at Congress. The first is Propranolol as an anxiolytic to reduce the use of sedatives for critically ill adults receiving mechanical ventilation, or the PROACTIVE trial. And the second, which Dr. Rochwerg served as the handling editor, is acetylsalicylic acid in the treatment of patients with sepsis and septic shock, a phase 2 placebo-controlled randomized controlled trial. Bram, you served as the handling editor for this, and I wonder if you can talk a little bit about why you selected this article, and maybe then talk for a moment or two about the role of phase 2 clinical trials in sepsis and the role of trial networks in doing sepsis clinical trials.
Yeah, thanks, John, and thanks for the opportunity to participate in this. It's fun to be able to chat with both of you about upcoming trials and studies that are going to appear in the pages of Critical Care Medicine. This was an interesting study, and I remember being sort of intrigued the second that I saw it come across my desk or from when you sent it to me. There's lots of good biologic rationale for using aspirin in inflammatory conditions, given its anti-inflammatory effect. Also, as an antiplatelet agent, platelet aggregation, microvascular thrombus, so implicated in the pathogenesis of sepsis as well. So it makes sense to look at an intervention like this. And you'll remember perhaps back during COVID, many folks, including the REMAP team, had looked at aspirin and its role in COVID. Subsequent meta-analysis didn't really bear out as a true effect. And so this group from Brazil, the BRICNET group, performed a phase 2 trial, as you said, in 5 ICUs in Brazil, where they looked at patients with sepsis and organ dysfunction. And those that got randomized to the intervention received aspirin at 200 milligrams a day for 7 days. Those randomized to the comparator arm received a placebo in so much that you couldn't tell the difference between, at least the caregivers and patients, between the intervention and those that were in the comparator group. Now, the primary outcome in this phase 2 trial was the change in SOFA score from day 0 to day 7. Remember, again, as I mentioned, it was a 7-day course of aspirin therapy, and so very sort of short term. The thing, and perhaps we'll get into it in a moment with the phase 2 trials, that they're not powered for sort of things like mortality and big patient important outcomes. And so the focus here on a continuous outcome, looking at organ dysfunction, maybe still patient important actually, but not to the degree that we're used to seeing, and not the prolonged endpoints that we'll often see in larger, more well-powered studies. They looked at a whole bunch of secondary, tertiary outcomes you would expect, things like mortality and organ dysfunction, but really importantly, and sort of key to a phase 2 trial as well, as they looked at adverse effects. And perhaps unsurprisingly with aspirin, the big one was bleeding. They built in or pre-cooked 2 interim analysis, one at 50% and one at 75%. And lo and behold, at their 75% interim analysis, they found a safety signal for increasing bleeding, major bleeding with aspirin, and actually stopped the study early at that point. And so when you look through at all the other primary outcomes, secondary outcomes, there was no difference between the 2 arms, other than this signal for an increase in adverse effects associated with those that got randomized to aspirin. And so, it was a well-done study, a randomized control trial. They used blinded intervention, which helps with decreasing the risk of bias. And so, again, very compelling, interesting, and we thought applicable to the readers of CCM across a diversity of disciplines, and important to select this as a late breaker for Congress. So that's my brief summary of, why we thought it was important in the study. I think the authors, the investigators in this case, made an interesting decision when they embarked on this. There was biologic rationale. And they probably were thoughtful. The Brazilians tend to be thoughtful folks, and BRICnet as well, a thoughtful organization, about whether to advance with a large scale phase 3 trial, perhaps powered for mortality, versus a phase 2 approach, more looking at surrogate endpoint and with a focus on safety. And listen, they chose the latter, and lo and behold, they were well justified in that, because actually seeing the safety signal, it's a good thing they didn't jump right into a phase 3 trial. And so, for interventions like this that maybe well understood in other contexts, but not used so much in the indication that it's being examined in, often I think that there is benefit, and especially those with potential safety concerns, benefit in looking at more of a phase 2 trial, because we all know that trials are expensive and they take a long time to run. And to some degree, they put patients at risk as well. And so to be able to do this phase 2 here, find that, maybe aspirin decreases organ dysfunction, but at what cost? And at least here we decided, I think, that the cost was not worth whatever impact it might have, given the increase in bleeding. And they were able to make that decision to shut this trial down and stop this intervention at this point, without proceeding with that larger and more expensive venture that probably would not have been fruitful. So, I think that there's many potential benefits to doing a phase 2 trial here. Again, fruitful. Sometimes it helps inform, feasibility, this sort of stuff of the larger trial, but I think it was a good idea in this case. And I've sort of alluded to your last point a couple times already, but trials groups are so monumental in being able to advance research questions. And BRICnet is a great example of one that's really come to prominence in the last few years. Looking at the productivity that's come out of BRICnet in the last little while is amazing. I'm very involved in our, as you know, Canadian critical care trials group. And we try to provide that research mentorship, nurturing of research programs, provide input on design and methodologic challenges, perhaps even something like trying to decide whether to go ahead with a phase 2 or a phase 3 trial. And I can't, you look at the successful studies that have been published in the critical care space in the last couple of years, 5 years, 10 years, almost all associated with very successful research networks and clinical trials groups like ANZIGS, like the Saudi group, the Irish group. I got to stop naming groups because I'm going to forget some that are play a monumental role in our landscape. But I think definitely why this trial was so impactful was given the support of BRICnet behind them.
Okay. Thank you so much. So, Dr. Evans, as incoming chair of FCCM Discovery, you played an important role with the Congress Planning Committee. And can you talk a little bit about the sessions that one might find late-breaking articles from journals such as Critical Care Medicine or other either critical care or general medical journals?
Yeah. Thanks, John. First of all, it's great to see both of you. It's always a pleasure to get to chat with you, especially when it's about science and clinical trials, but just in general as well. From that, and I would say there's lots of fun things about being involved with SCCM Discovery. So, if you were watching this as an SCCM member and interested in clinical research and clinical trials, don't hesitate to join the Discovery Network. There's always lots of good conversation to be had and lots of potential for collaboration there. But one of the roles that I find particularly enjoyable with being the vice chair of Discovery currently is this liaison to the program committee and liaising with journal editors like John and like Bram around what are the late-breaking studies that can be presented at Congress from that. And so it's a really, really fun part of my role. And what we're looking for in general, when I think I can speak for the Congress co-chairs this year, as well as myself, obviously, as the Discovery vice chair, we're really looking for high quality, clinically relevant, impactful studies that are going to be of interest to a large number of our Congress attendees. And so critical care medicine, as John mentioned, has 2 late-breaking articles that are going to be presented at Congress. This BRICnet aspirin trial is one of them. The other, as John mentioned, is the proactive study of propranolol as an adjunctive sedative to reduce use of other continuous sedation in patients who are mechanically ventilated. And I think Bram touched on a couple really, really interesting things that really, particularly with regards to the aspirin trial from BRICnet, really kind of made that rise up, obviously in our minds, to be a late-breaking session. Was there's a clear safety signal there. So even though it's an early stage phase 2b2 RCT, the safety signal is enough that it impacts clinical practice. So it makes all those decisions for us around, is this an impactful study? Is this clinically relevant? And clearly it's a high quality group from that. On a personal note, as somebody who's very involved with discovery, it's also really great to see trials being presented at Congress that are from Clinical Trials Network. And I think that as we continue to build FCCM discovery, that's one of the things we hope to see more of coming out of discovery as well, is these impactful multi-center trials that can be presented at Congress, hopefully as late-breaking sessions from that. So that's kind of my overview of what we're looking for from that. I would just put a plug in to those who are going to Congress to, please go to these trial sessions. It's really an amazing opportunity to hear studies being presented by the people who did the studies. And we don't get those opportunities a lot in what we do day to day. So it's really an awesome opportunity to be there, to ask questions in person. There'll be plenty of opportunity, even the sessions that are in these so-called thought leader sessions, which is the sort of renamed plenary sessions. We'll have opportunities to continue the conversation outside in the hall after the presentation. So you can get your questions answered by the folks who did the study, which I think is a really amazing opportunity.
So thank you both. I'd like to thank Dr. Rochwerg and Dr. Evans for participating in this month's video related to the February issue of Critical Care Medicine. Have a fine day.